Okay, so today, everybody, welcome. We have Dr. Sarah Pauly on. I'll introduce her in a minute as well. Dr. Devine will be joining us shortly. We are going to hear about cannabis and the developing brain, which I'm super duper excited about. And so it was fun when I was just telling Sarah that I was presenting in my 7th graders classroom on Monday, and I only did like 2 slides for the drugs, but I spent more time on cannabis just with it, the legalization and all of that. And it was interesting to see a bunch of 7th graders like kind of get shocked at different things that they just didn't know. So it was exciting. And hopefully I actually said what you're going to say. To go back and change my whole talk. Just kidding. Okay, so upcoming next week, we have our friend Sarah Spencer coming back all the way from Alaska, excuse me. And then Sarah does come back again, and you can kind of see what's coming up. Have a lot of neat people we've been in contact with lately that I had met when I was in Atlanta giving a presentation at the National Summit. So pretty exciting things coming up into June. If y'all could turn your videos on, I'm sure Sarah would appreciate that. And as always, if you can change your names so we can see who you are on Zoom World, everybody kind of already does that. If there's more than one person in your room, please chat that in so Katie can make sure everybody gets credit. And at the end, after the session today, you will get the email and all that with the information on how to get your CME credit. As always, technical assistance, we are here for you and available. So any kind of questions you have, especially with getting a program going or Suboxone going or any kind of whatever questions you have, don't hesitate to reach out either to Dr. Devine, myself, or Erin, our nurse, and there's Erin's email and all of our cell phone numbers. Okay. The core website, so our website that has all the information on it, how to get onto Echo, how to start program, there's all sorts of information on there. And finally, y'all, the manual is up. Can't believe it. It's finally there. So you can go to either of these sites. This is the Strata site. It's also at the Minnesota Department of Health site. If on the Strata site, you go to, if you type Stratus and then type Center for Opioid Resources or CORE, you get to this page. If you scroll down on that page, you will see find SUD clinical resources. Click on that, and there is where the manual is. So it has all sorts of educational things as well as all the paperwork that we have attempted to create and come up with an update over the years. So with that, I would like to introduce Dr. Sarah Pauly, who is got a really long, a bunch of stuff she does. Hazelton Betty Ford, she does a bunch of stuff nationally, and most recently joined LE Mental Health in Minnesota as the director of addiction psychiatry. So she's got a super awesome Instagram, y'all. She makes these cute little Instagram videos. They're just fun and educational and entertaining. So, all right, with that, Sarah, go for it.
Yeah, well, thanks for the introduction, Heather. That was so kind of you. And I'm getting over a little bit of a cold, so I got kind of a scratchy voice, but yeah, I'm really excited to talk about this today. I feel like we're at like a pinnacle moment in history for the state of Minnesota, where this is so important for us to adequately address with our patients and educate families and educate young people about marijuana. Because with the legalization, which I'll talk a little bit about within the slide deck, just this past Friday, I think what we're going to see and what data has shown in other states where marijuana has been legalized for recreational use is we're going to see an increase in youth cannabis use, even though it's not legal for young people. And so how do we help? And, I've been, as Heather mentioned in my Instagram videos that I do, I've been part of what I would like to do is to try to get the message out there that, rather than us as, individuals who work with substance use, I'm like very, worried about young people with what's going to happen here. But rather than kind of be anxious and just sort of like put my stake in the ground and say it should be illegal and this was a mistake, I want to really try to educate parents and adults in the community about what they can do to try to keep kids protected against exposure to marijuana, and also to make sure that we're giving our young people an adequate picture of what marijuana is and that we're not glorifying it or making it seem like it's no big deal. But anyway, we'll get into that a little bit more. For those of you that have seen me talk before, you know that I often start my talks this way. And so this is pictures of my dad. My dad's name was Steve. He died when I was in college, secondary to alcohol use disorder. He had struggled before I was born with alcohol use, and then reached a really long period of sobriety, actually from the time I was born until I was about 11 years old. I had a brother that passed away when I was 11, and that, as you can imagine, really sent my family into a lot of, period of trauma and stress. And then part of that was that my dad relapsed on alcohol, and then went into treatment a number of different times, did a lot of different types of treatment, everything from like naturopathic docs all the way to like, doing AA and doing kind of 12-step recovery, taking medication, and then unfortunately passed away secondary to having a heart attack during a withdrawal seizure at our house. And so it was, even though I knew that he was really ill, and I think, those of us that work with addictions, right, we can tell that sometimes our patients are really, almost like, I wish that there was a hospice for patients that had substance use disorders sometimes, right? Because it's like their illnesses are so progressed that it's really hard to envision another type of outcome for that patient other than death at that point, because their illness is so far progressed. And so, it was a surprise in that, it's not like he was in a hospice or he had cancer or liver failure or anything like that. We weren't necessarily expecting it, but in some ways it wasn't a surprise. And I tell the story because I really want us as a community to normalize the experience of families that have someone who's experienced substance use or mental health conditions, and normalize that for the people themselves that are experiencing it. A lot of us that are in medicine, we have reasons why we chose the specialty that we chose. And just as, someone might share the story of how their mom struggled with breast cancer, and that's why they're an oncologist or why they're an OBGYN doc, right? Like, I want us to normalize that for substance use too, because it is a medical condition, just like other medical conditions. And I know I'm preaching to the choir here at the Echo, but this is just my little piece of trying to make a difference and sharing my story to try to normalize this for people. So yes, we're going to look at trends of cannabis use for young people. We're going to talk about why cannabis exposure in the brain between adolescence and young adulthood is different than when we talk about a 30 or a 40-year-old choosing to use marijuana recreationally. And then I use some case examples and kind of talk through some really approachable, I hope anyway, early intervention and kind of intervention strategies that we can use in the office that really only take a couple of minutes. We're not talking about things that you need to like be an expert in, but I'm always surprised. And when I was first learning about brief intervention, I was surprised at how things that a lot of us do naturally are evidence-based intervention to prevent the progression or the onset of substance use. And so I think we can all feel good about that. But we're just going to review that a little bit. Don't have any disclosures. As Heather mentioned, I'm actually wrapping my time up here at Hazelden Betty Ford. I've been the medical director of youth services here for 2 years, and I'm moving to LE Mental Health to do outpatient co-occurring treatment for adolescents and young adults. That's really where my heart is I want to provide a place for patients to come to between episodes of acute care, because I feel like that's a huge gap in treatment for patients with substance use and, co-occurring illness, is that there's not a place for them to go once they're done with IOP or once they're done with residential treatment. They don't have somebody who can manage everything for them. So I'll be still here in Minnesota, in Golden Valley, seeing patients. So this is just a case that we can use to think about as we go through. I'm sure you guys all have your own cases that you can think about when it comes to patients that you've interacted with, but this is just an example of kind of a typical patient that I might see. So 16-year-old adopted female, there was a biologic family history. They think of substance use disorder, and they think there probably was in utero substance exposure, but the adoptive family isn't quite sure because they don't have the full history. Patient seen in primary care clinic, has controlled asthma, was diagnosed with ADHD at a younger age, based on, difficulty with attention and concentration and impulsivity and hyperactivity. And they do have supports at school for that. And then prescription wise, they're prescribed methylphenidate, or let's just say Concerta, for treatment of their ADHD. And they come in because parents have noticed that there's been increasing difficulty with sleep, patients not really eating quite as much. They've been having these angry kind of oppositional outbursts when parents have been trying to limit set. And then the patient hasn't been doing very well well at school. And the family really thinks, and mom kind of phrases this as, I think we need to talk about maybe changing the ADHD medication. I don't think it's really working anymore. And then we wonder if she now has depression because of these symptoms. We were reading that it could be from depression. And so she might maybe needs to be on like an SSRI or Prozac or something like that. And so just to quickly visit this, because some clinicians get confused about this, and I've heard this in the community. So people will sometimes say things like, I have a 16-year-old and I'm seeing them in my mental health clinic or in my primary care clinic, and they disclosed to me that they're using substances. But because of this federal law, 42 CFR Part 2, I can't tell the family that the patient is using substances because I don't have a special release and I can't do that. And so really, I want people to know that that 42 CFR, or that additional protection that exists for substance use treatment and substance information, only applies to federally funded substance use treatment centers. It doesn't apply to general mental health clinics. It doesn't apply to primary care settings. And so really, regular HIPAA applies to you, and then Minnesota state law applies to you in those situations. And so in Minnesota state, it's written that if a health professional or provider feels like it would be in the patient's best interest due to safety concerns, that they do disclose to the family what they've discovered about any kind of health related topic, including substance use, that it is okay to disclose that. And when I say this, I'm saying we do this in a patient-centered way, right? We don't end the appointment with the patient and then call the parent on the phone or pull the parent in and then, unbeknownst to the patient, say, well, your kid told me that they're driving while smoking marijuana, so we need to talk about that, right? You want to do that with the patient first when you're by yourself with the patient, and explain to them that you have concerns about their safety and that together you have to figure out a way to be able to talk to the family about it. And so really asking the young person to brainstorm with you how to approach this to be able to ensure that the child will be safe, and do this in, again, kind of a patient-centered way, rather than, doing it kind of after the patient leaves or without the patient knowing. This is kind of a plug for screening your patient for substance use disorders. I'm sure that there's been echoes and you guys have heard about this before, but this is my personal favorite screen. I really like the craft. It can be done by the clinician or can be done by the patient individually. It's free. If you go to the website that's listed there, you can print out as many copies as you want and give them to your patient. It's very evidence-based for screening for substance use disorders in adolescent and young adult populations. Research has shown that when we rely on our judgment to determine who we should screen, that we're actually really bad at deciding who needs to be screened and who doesn't need to be screened, which is okay. We're all impacted by internal bias, right, about who we think might have a problem and who doesn't. And so if we can just screen all of our patients, we're going to be able to be really helpful, I think, particularly in a situation like this patient, right, where it's important that we know that the story isn't really as straightforward as just being depression or just being ADHD, right? We really need to know that there's actually more going on here in order to make an appropriate treatment plan. So we can just pretend that this is kind of the responses that our patient Eliana gave us. And based on these responses, there's, a 79% chance that she is struggling with a substance use disorder. And so you ask her about this, she kind of explains to you what she's using, says, I use half a joint before bed. I use a half a joint in the morning because school really sucks. And it actually helps me with my concentration because it's a treatment for ADHD for me. So that's why I do it. And then my friend has a dab pen. And so I use that sometimes when I'm at school. We do that in the bathroom. And then I've also used this thing called Delta 8. It's legal. And so it's not addictive. And so I'll sometimes do that, especially if I can't get marijuana, because, then I can sleep and it helps me. So this is not an uncommon question that I get. Sometimes adolescents are pretty spicy, right? When you see them, sometimes they're not quite as direct as this, but, basically saying something to the effect of, I don't want you to lecture me. I know that I'm not supposed to smoke marijuana. I know that it's bad for me, whatever, but you probably they might say something like you don't understand or you don't know the same things that I know about it. And really, I kind of use this term to describe my style with my patients, but it's like radical transparency, essentially. So I try to just be as open and honest about what my brain is thinking in that moment with my patient as I can be. And so I'll usually say something to the effect of, you're right, I probably am really biased. I probably do approach this from a really different kind of viewpoint than you're approaching it. And I think both of us have really valuable things to kind of think about this. But what it sounds like you're not, you know about this, like you've used marijuana, maybe you've done research about it. Can you tell me a little bit about what you know about it, or what kind of things you're worried that I'm going to say? Because I agree with you that my goal is totally not to lecture you. That would be a complete waste of our time today. And I don't want to do that. So why don't you tell me a little bit about marijuana, but a little bit about like what you know about it and what's helpful about it as a way to kind of open the conversation up. And for those of you who are familiar with motivational interviewing, this is a very motivational interviewing type approach where I often will start my conversations asking about what do you find to be helpful about marijuana, as a way to really let my patient know that my goal is not to do anything about convincing them of anything or to like lecture them. So, the beautiful part about motivational interviewing is that people, and this is true with teenagers too, will automatically, once they start to talk about how awesome it is, their brains will unconsciously automatically throw in things that are not good about it. And that's where you as a clinician can really use like your fish hook and like snag into those things that they say, right? Like I can't tell you how many times I've got a kid who is committed to being California sober, which means that they're not going to use opioids, they're not going to use methamphetamine, but they're totally going to use marijuana when they leave because it's great and they love it. How many times they'll start to say how great it is. And then they'll say, but I know it's probably not good for my brain. And then that's when I use my, where I put the hook in and I say, oh, that's interesting. So what do you mean when you say that? To just let them kind of expand upon that more. And then that's where I start to introduce some of my psychoeducation in these kind of like little brief spurts. So just so that we're kind of all on the same page, I'm not going to spend a super long time on this because this deck unfortunately has like way too much content and I've tried to cut it down. But so cannabis, when we talk about cannabis, what are we talking about? So we're talking about the plant, which contains many, many different types of chemical compounds, some of which are considered psychoactive, which means that they impact the way that we think and we feel, and they impact our behavior. Some of them are either not psychoactive or what we would say minimally psychoactive, meaning that they're not intoxicating, where you're not going to have such an altered experience that you become like less attached to reality, but they may make you feel calm, or they may have some kind of a more subtle effect. And then there's compounds that don't kind of interact with the brain at all. And so federally, what is legal in the United States is hemp-derived products, which means that you can breed a cannabis plant that has less than 0.3% THC, and that is considered legal. And so other types of compounds that are in the cannabis plant at a federal level are not regulated. So it can have as much CBD as you want it to have. It can have as much Delta 8, Delta 10, Delta 12 as you want it to have. The only thing that's regulated is the amount of THC that's bred in this particular type of cannabis plant. And you'll see that come up as we talk through how is it possible for things to be legal at the state level, but illegal at the federal level. And then this is helpful for me. I keep this and look at this sometimes because as somebody who's not like a recreational smoker of marijuana, I don't necessarily know these things off the top of my head. When a patient is saying an amount that they're smoking, I can't necessarily visualize that myself. And so, just kind of having an idea of how much marijuana is in whatever it is that the patient is saying that they're using. A lot of young people now are using electronic delivery devices, and so e-cigarettes to vape THC and marijuana products. That's really popular. It doesn't smell. And so patients can smoke it. They can easily take it to school with them. A lot of my patients, especially in Minnesota in the winter, will say that they like it because they don't have to leave their bedroom. They can just do it in their bedroom, and then families don't know about it. And partly what's concerning about that, and this is a piece of education that I give patients, and particularly if I'm doing harm reduction, I'll try to move them away from use of vapes and concentrated products because they deliver really high amounts of THC to the brain. And so, this is not very scientific in any way, but when I do outpatient work and I measure levels of THC for patients, my patients who were using vapes and concentrated products like waxes and oils would have THC levels, if they were, daily users, between like 1,000 and 2,000. And my patients who were using bowls of the flower or the plant would have levels of like 100 to 200. So you're really giving yourself a lot of concentrated THC, and then you're putting that into your brain when you're using these concentrated products. And as I mentioned, things like Delta 8 are not federally regulated, and so they're not considered federally illegal. And different states have different approaches to the management of other compounds within cannabis that are psychoactive that are not Delta 9 THC. So I'll go back to that other slide in a second. But so what is Delta 8 and like Delta 10 and Delta 12? You'll hear people talking about this. So essentially, it's very similar to Delta 9. They just have varying different affinities for the cannabinoid receptors in our brain. And so Delta 8, for example, has a lower affinity for those receptors. And so people will talk about it as being like a light version of Delta 9 THC. It does still produce intoxication and the same type of risk of addiction as Delta 9 does. And so the idea that it's not addictive or that it's safe is not the case. It's just that it's different than Delta 9 and it might be less potent, but it still can have the same effects. Minnesota has regulated Delta 8 and other types of psychoactive cannabinoids dating back to July of 2022, when that like edibles bill passed. One of the benefits of that was that they did then offer regulation within our state where these things are only legal to sell to people over the age of 21, and they can't just be sold anywhere. That wasn't the case actually prior to the summer of 2022. Prior to that, anyone of any age could purchase something like Delta 8, and you could get it at various places like gas stations and things like that. It's new to me anyway. I hadn't been as familiar with it until I heard a patient talking about it, but it's called THCP, and it's growing in popularity right now, partially because it's considered federally legal, so it's easier to manufacture and sell. But it has the strongest known affinity of any compound that is naturally occurring within the cannabis plant for cannabinoid receptors. And so there's a concern that if this grows in popularity, particularly if people are vaping it, so they're getting higher concentrations of it, that it might act similarly to the synthetic cannabinoids. And so those are like things like K2 and spice, which are synthetic cannabinoid receptor acting compounds, which have a really high risk of creating psychosis and other types of more immediate harm. And so there's some concern that if THCP continues to grow in popularity, that it might produce similar problems to what we saw when people were using and when synthetic cannabinoids were more popular. And just to kind of quickly review to make sure that people know, so prior to what happened this past Friday, over the summer of 2022, there was a bill that people sort of like joked accidentally created legal edible marijuana in the state of Minnesota, because I think a lot of legislators didn't quite understand what they were saying yes to when it went through. But what's happened as a result is this huge industry in Minnesota, particularly. We already had a really big craft beverage brewery industry here in Minnesota for like craft beers and that sort of thing. And a lot of those same places have now shifted to making craft beverages that have THC in them and selling them in the same places. So you would go to the brewery to hang out and you could choose between either a beer or an alcohol beverage, seltzer, or a THC beverage. This is really growing in popularity in Minnesota. And there's certain limits here as to what can be in these edibles in Minnesota and how much THC can be in them. And this is just an example of some products that you can get in the state of Minnesota right now, including like Indeed Brewing that has this THC product, and there's others that have them too. And then in case anybody's interested, this is a study that was done to determine, so somebody who is not a routine THC user, how many milligrams of THC will get them high. And so, 5 milligrams is kind of the limit that's in beverages that you can purchase, like a can of a drink at a brewery. And generally speaking, it's kind of like 5 to 10 milligrams that will start to create the feeling of being intoxicated for somebody who doesn't usually use THC. And then really when you get to 25 milligrams and above is when you see really a significant intoxication. The part that I think we should really be educating our patients about, which is so important, is that the time that it takes to have an effect on your body and for you to feel like you're getting something from it is a lot longer than alcohol. And so if you're going somewhere with friends, right, to go hang out, and your friends are ordering a beer and you order a cannabis drink, you're not going to feel the effects of that until potentially an hour after you drink. And the max effect isn't going to be an hour and a half to 3 hours after you drink it. And so what I wonder about is, I just envision myself, right, like going to the brewery with friends. It's like, everybody's kind of starting to get a buzz. People are joking and having fun. You don't really feel anything because you've chosen to drink the THC beverage. You're like, this is kind of annoying. It's really loud in here. So then you either start to drink alcohol beverages in addition to that, or you go and get yourself 1 or 2 more THC beverages. And then here you are 3 hours later, everybody's leaving and going home. And they're sort of maybe like better at driving because they've also gotten food truck food or whatever. And then here you are reaching peak effective of your THC, and then you're about to go home. So I think we really need to explain to patients that this is a different type of experience, and maybe you should plan your evening a little bit differently if you're choosing to use THC instead of something like a beer. This bill that passed on Friday, it passed the House earlier and then the Senate on Friday. Likely based on like what we see in other states that have legalized recreational use cannabis, we're not going to actually see people being able to like purchase this or do this for another year. But essentially this bill combined the ideas of decriminalization, expungement of prior offenses, and legalization and commercialization into one bill, which I think is important to kind of mention, because a lot of the proponents of this bill were very, very focused on pushing the aspects of expungement and decriminalization, which I agree are extremely important, right? Like, I think it's important that we acknowledge that the making cannabis illegal and persecuting people for possession of cannabis in Minnesota was a form of systemic racism. Like, that's real and that's true. And it was possible to decriminalize and expunge without necessarily allowing for commercialization of cannabis recreationally in our state. But that wasn't something that like the industry, the cannabis industry, was interested in pointing out. They were very interested in like putting these things all together, because a lot of people, as they should, get really passionate about decriminalization, which I think is really good and important, but not the general person not understanding that that can happen separately from legalization. And so there's different stipulations, and these are going to likely even change a little bit more from what was originally approved. So people can grow a certain amount of cannabis plants for personal use. You can purchase seeds online and order them. They're advertised, as having different fun names and different kind of like combinations of ratios of different types of psychoactive to minimally psychoactive compounds that supposedly do certain things or treat certain things. There's not research or evidence that actually supports a lot of the things that the marketers or the, people who sell this promote, but people get very into it. There's whole blogs, websites, all kinds of stuff completely dedicated to, extolling the benefits and drawbacks of various different combinations. But again, we just don't have the scientific literature to know if these things are true or if this is just sort of like pretend kind of like fun marketing. They're only licensed growers can sell products. There's going to be a process by which people and organizations pay money to receive a permit to allow people to smoke or to use on their property. There's going to be an additional, I think the tax was actually increased by the Senate to 10% on top of regular sales tax. And then our state has decided that they want to try to, in some ways, I guess, make up for some of the systemic racism that has been done over time with the preferential persecution of people of color for marijuana by giving loans and grants to people of color who want to grow marijuana and sell it, and also other types of small growers in our community. And their idea is that this is going to be helpful so that it's not only these larger companies, probably owned by white men, who are able to grow and to sell in our state. There is a former pharmaceutical cannabinoid product. It's used for various different things that have FDA approval. There's some evidence in literature that it can be helpful for patients to taper them off of marijuana using something like this. You are never going to get insurance approval to pay for being able to do this. So to me, it's kind of like this, pipe dream. Like I could try, but it's going to involve submitting a prior auth, which is going to be rejected, trying to appeal, and it's going to be rejected. So in the real world, I don't know how likely it is that we actually can use this for marijuana use disorders until something changes with either FDA approval or insurance coverage. And then just to go over CBD quickly. So CBD, some people will say it's not psychoactive, which is not exactly true based on the definition of psychoactivity. It does interact with the brain, including with various other types of neurotransmitters, not just with the cannabinoid receptors, but it is an agonist at some serotonin receptors, which is a mechanism that we use for some of our other antidepressant and anti-anxiety medications. It also modulates opioid receptors. It is bioactive, and there's a lot of interesting research that's being done in how it interacts with support cells in the brain. So, glia cells, how it helps the blood-brain barrier and kind of reinforces the normal permeability of the blood-brain barrier, which we think is sometimes impaired in certain types of chronic conditions such as diabetes. And there's some evidence that it might actually help protect the brain from development of different types of dementias that involve things like diabetes or ischemic injury, which that's super cool and super promising. And I hope that research continues for us to be able to have more evidence to be able to know if CBD is going to be something that's helpful for our patients. And there is a pharmaceutical version of CBD. Right now, it's FDA approved for specific types of pediatric epilepsy. Again, you would not be able to pay for it or get approval from insurance to use other things now. But again, maybe in the future that will change and we'll be able to use it for prevention of different types of dementias or other types of things. What we know about what CBD does and what the internet and people who sell CBD claim that it does is very different. There's like a million memes online, which I really like memes about like how CBD cures all of your problems. Like you're a mom, you're stressed out, use CBD. You have a headache, use CBD. I mean, it's like CBD does everything for everybody, for all the things. And there's really not a lot of evidence that that's necessarily true. And CBD does have side effects. And so it isn't just kind of this benign thing. And so sometimes people will be using it and they may or may not tell you if they're coming to you for treatment. And so I'll sometimes ask because sometimes they'll be having a problem and then I end up attributing it to a medication that I've prescribed and thinking they're having a medication side effect when it really could be because of, again, a supplement they're using such as CBD. The big problem with CBD in the United States, and we're behind other countries in this regard, is that our products are not regulated by the FDA. And so there's really no standard to which companies need to uphold to be able to sell their products. And so this was a really interesting study that was done by a nonprofit organization out of Israel that is kind of the world leader on research of cannabis and cannabinoid products. And they specifically focused on the United States and looked at almost 2,000 different products that are for sale here in the US that people buy that are CBD products. And just wanted to look to see, how many of them were what they said that they were, how many of them actually fell within legal guidelines federally in the United States. And the research is just kind of abysmal, right? Like 84% had outside of the recommended variance of THC, meaning that they had more than that 0.3% THC. Only 13% were tested for purity. And so, we know that some of these products contain funguses and heavy metals and different things like that, particularly if you're vaping that and putting that into your lungs, that can be really dangerous. And really, we can't verify that the products that our patients use are what they say that they are. And so particularly they noted that beverages and topical products were the least likely to be tested and to actually be what they say that they are. And that places that manufacture a small amount of products, so only one or two products, were more likely to actually test them than, companies that are manufacturing a huge amount of products. Really, like the main take home from this slide is that I want people to, when you think about THC and think about CBD, think about inhibition of the CYP450 system. So these compounds are inhibitors at a lot of different enzymes within the liver. And so they can impact drug levels. And this is just an example. So of two of the enzymes that CBD inhibits, and these are medications that are metabolized through that enzyme. And so you can see things happen to patients. For example, I had a young person who I started on Lexapro for treatment of anxiety. Mom was really nervous about the Lexapro, was worried about side effects and suicidality. We started it at 5 milligrams. We increased to 10. When I increased it to 10, patient actually had symptoms that looked kind of like serotonin syndrome. It wasn't to the point of going to the hospital, but they had hyperreflexia, they had fever, some other things that were really unusual and concerning. And I was sort of like, oh no, of course, because his mom is also anxious about the medication. And I'm wondering if I need to do, liver enzyme genetic testing, like something like GeneSight. And then when I talked to mom, she ends up telling me, well, no, I've actually been giving her CBD gummies. The package says to give her 1, but 1 didn't do anything. So I've been giving her 3 to help her with her sleep. And so it turned out, right, that likely what I thought was happening was that she was getting higher than expected levels of Lexapro because of using CBD. Mom ended up agreeing to just hold the CBD for a while because she wasn't sure it was helping anyway, to see if we could get the Lexapro to help. And we restarted it at 10 milligrams, and patient actually did just fine, didn't have any side effects or problems. And the medication ended up actually being really helpful for treatment of the generalized anxiety that the patient was having. So, again, it's important to talk to our patients about this information when they're talking about using CBD. And again, not to come at it from the angle of don't do that, it's dangerous. You could be vaping heavy metal, so it's a bad idea, right? That's not like a patient-centered approach. It's more like trying to help them think about the risks and the benefits of the choice that they're making and direct them towards things that might be a little bit more safe. For example, are you open to maybe using CBD chewies instead of vaping CBD? Because I think that might be a little bit safer for your lungs, or if you're somebody who's a daily THC user, are you open, if you're not open to stopping THC, are you open to kind of transitioning to doing some CBD in place of the THC that you're doing? So, diagnosis of cannabis use disorder. So really people sometimes think that this is complicated or there's some magic behind a Rule 25 assessment and that a normal clinician couldn't just make a diagnosis of a substance use disorder. And that's not the case. The DSM-5 has criteria for all of our substance use disorders. The criteria for cannabis use disorder are the same as other substances. And so really you just go through these criteria with your patient to determine if they meet criteria or not. A couple pieces I just want to point out, just because somebody is smoking marijuana, and even if they're smoking it every day, doesn't mean that they have a cannabis use disorder. Nowhere in the criteria does it say this amount of using equals a use disorder. It's based on how it impacts their daily functioning and kind of their otherwise ability to do their tasks of daily living. And so only 50% of people who choose to smoke marijuana every day actually have a use disorder. So it's important to ask these questions to determine if this is actually a problem. And it's easier for an adolescent to meet criteria for a use disorder with cannabis than it is for an adult, partially because of the additional kind of oversight and control that children have or even young adults have as compared to an adult. So for example, right, it's easier for us to determine that there's been recurrent interpersonal or social difficulty for a young person potentially than an adult, because a lot of parents don't want their kids smoking. And so when they find out their kids smoking, there's conflict, there's arguments, parents take the marijuana stuff, the kids start sneaking around and doing things they're not supposed to do in order to continue to receive or get the marijuana. And so, you might have a child who is a smoker who meets criteria for use disorder, whereas you have an adult smoking the same amount of marijuana, but then they're not meeting criteria. So, and this could be a problem of the criteria. I think it's good in that it doesn't necessarily, it's not placing the focus on vilifying the substance and saying that any use of the substance is bad. It's more like, is the substance creating problems for this person in their life? So I only have a little bit of time left because I want to make sure we leave some for questions. But this last part that I'm going to go through is really, I've boiled down how to do psychoeducation about cannabis into like 4 main points for families and for patients. And so I will usually choose one of these 4 when I'm talking to families and sprinkle it in depending on the topics that we've been talking about, or depending on where the child or the family like leads me in the discussion. I don't want to overwhelm them by kind of bringing up all 4 of these at one time, but that's the way that I've kind of conceptualized this. And so I open it up in a patient-centered way, right? Just to note, if I say, I want to talk a little bit about your marijuana use, and the patient says, no, I don't want to talk about that. Like, what do you do with that information? And again, this is where my radical transparency comes into play, where I say, okay, that's fine. Like, we don't need to talk about it. I mean, I'm just curious, is there something that you're worried about? See if I can get them to talk about that. And if they're like, no, I just don't think it's relevant and I don't want to talk about it, I'm not in the mood, right? Then I'll say, okay, well, that's fine. We don't have to. We got to come up with a plan for when I go to get your mom to bring her back in here, right? Because she's going to ask, okay, so did you guys talk about the ADHD? Did you talk about the depression? Like, what are we going to do? Right. And like, I got to tell her what the plan's going to be. So what I'm going to have to say is, well, I wasn't able to get all the information today that I need for us to come up with a plan, and that's okay, but I need you guys to come back for a follow-up appointment so we can keep talking about it. So does that make sense to you, that that's kind of what's going to happen here? And sometimes then the kid will say, okay, fine, because then they're like figuring that once they get in the car, their mom's going to be like, what in the heck happened in that appointment? Why wouldn't you answer her questions? Were you rude? Like bring it up in that way. So they'll go ahead and talk about it. And sometimes they won't, and that's okay. And then maybe when they come back, they'll be in a different spot and we can talk more about it. So just to kind of, tenets of brief intervention, we kind of went through some of these already, but they're important to keep in our mind when we're having these discussions, because I do get patients sometimes that come, and it's good in that they've ended up in care. So I'm happy about that. And they're also really pissed because basically they went and they saw their pediatrician or their doctor, and the doctor was really worried, as they would be, especially knowing this kid probably since they were a newborn baby in some cases. And they said, like, what are you doing? Don't do that. No, we need to tell your mom, like, okay, your kid is smoking marijuana, and like you need to call Hazel and Betty Ford because they have to go to rehab. Like, this is not good. Like, this is really dangerous. Right. And I totally get where that clinician's coming from in doing that, but it takes a lot of work then after the fact to rebuild that relationship with that teenager after that's happened, once they're done at rehab and they come back to you. And so, if it's possible to do this in a more patient-centered way, I think it's going to result in maintaining that relationship with that kid and with that family potentially in an easier way. Okay. So let me go ahead to, so my 4 reasons. So reason why adolescents, and we'll talk a little bit more about this when we talk about in my next talk, but reason 1 why marijuana is different for teenagers than adults is that when you've got a normal teenage brain and how a normal teenage brain functions, and then you combine that with cannabis intoxication, you get not good situations. So you've got, it's normal for a teen, right, to be pleasure seeking, impulsive, have a preference for new and exciting things, wanting to do what their friends are doing, not being able to think through the consequences of the choices that they're making. That's normal teenagehood. And then you combine that with being intoxicated on something like cannabis, where you've got slowing further in your executive functioning and your thinking, a further feeling of invincibility, decreased intellect and IQ, impairment in motor skills, and you end up getting kids accidentally hurting themselves, or, more likely to engage in suicidal behaviors, more likely to engage in physical violence with other people and self-harm. And so they have an increased risk of exposure to bad things. And this is the case with driving. So a lot of my patients will say that, like, marijuana doesn't impact my driving. It actually is different than alcohol. Alcohol is really bad to drink and drive, but with marijuana, like, I'm actually a good driver. And it's interesting. And I tell my patients this, and a lot of them think that this is kind of funny or like, curious, but I say, well, it's actually interesting because when they do studies of people, right, like they tell them to like, just smoke on your own. We won't ask you any questions, come here and then do this driving simulator test. And then afterwards, we're going to ask you questions about how you did on the driving simulator. They find that people actually perform just as poorly with driving when they're under the influence of marijuana as they do when they're under the influence of alcohol. But the difference is when they ask them about how do you think you did, people actually feel like they did a good job. Whereas when you ask people who drove while they were drunk with alcohol how they did, they say, I did terrible. And so there's something about marijuana that really impacts the person's ability to have insight into their deficits at the time of intoxication, which again is pretty dangerous, right? So like if you think you're actually just fine, you're not going to sort of be extra careful or do things differently than if you kind of realize that you're not doing a good job. You might be able to motivate more extra resources to try to help yourself. And so, a lot of kids, when I tell them that, they'll be like, oh, that seems really messed up. That doesn't seem safe. And I'm like, yeah, it is kind of a curious thing about marijuana and how it impacts the brain, again, differently than alcohol, but something that can add to kind of the risk. Reason number 2 is that we know that marijuana use in the teenage years contributes to worsening mental health, both during teenage years, but then also into adulthood. And so those people who smoke marijuana when they're teens, when they're adults, are more likely to have increased complexity in their mental illness, more likely to have attempted suicide. They're more likely to have exposure to trauma, which I can get because, right, like if you're intoxicated and you're doing things that are dangerous, you're more likely to have something bad happen around you, which then would create trauma. And that can also be, increase in family conflict. You're more likely to have resistance to treatment of your mental health conditions. You're more likely to experience medication toxicity. And then we get into this idea of psychosis with marijuana. This is of particular importance, especially for kids that have a family history of psychotic illness. This is a point that I think we need to spend time doing some education. And this could even be, like if you're seeing a kid and they're like 10 and, you don't think they're using anything, or they're not using anything, and that there's a family history of psychotic illness, I think it's important to really explain to the family and to that child that for them, marijuana exposure is going to be different than probably for a lot of other people. That we actually think now that cannabis can contribute and be a causal factor in the development of schizophrenia for people that might carry a specific kind of genetic risk. And we don't necessarily know that genetic risk because we don't test for that. They test for it in research, but we don't test for that like in our offices. And so the best that we can do is to associate it with family history at this point. But, generally speaking, it's extremely risky for somebody with a family history of psychosis to use marijuana because you're really putting yourself at an increased risk of development of either bipolar disorder type 1 with psychosis or schizophrenia. And I don't have time, but I have this like really sad story of a patient I actually just saw 2 days ago, again, who has schizophrenia now as the result of a family history of psychosis and early cannabis use beginning at the age of 14 that kind of waxed and waned. But I'm not sure this person would have had schizophrenia if they hadn't smoked marijuana. They were extremely high functioning prior to this, actually being recruited for Division I athletics at a college when they were already 15, and now have just kind of had complete derailment, and are probably going to have to live in a group home or with their parents because of how significantly impaired they are. And then just to be aware, sometimes kids will present with what looks like depression, but really it's from the marijuana use and it's what's called amotivational syndrome. And so regular cannabis use can cause this, not in everybody, but in some people. And it's also more likely to happen in young people than it is to happen in older people. And so it's really important to screen for how often a person is smoking because someone might look very depressed, but really what's happening is that they're having this reaction to the marijuana that they're using. And then withdrawal can also look like a lot of other things. And so this is something else I explain to families is that it might look as though your child has a really significant other type of mental illness when really what's happening is withdrawal. And this happens a lot in acute care mental health treatment because what the story will be is that the kid wasn't doing well. Parents realized or found marijuana in the kid's room and they took it away. And then the kid, one day to, that next week has a complete meltdown, has suicidal thoughts, ends up in the ER for cutting or saying they're going to kill themselves, is irritable, can't sleep, stops going to school. And the parents are like, what in the heck? Like my kid. And then the kid will say, well, it's because the marijuana was treating my depression. And now you took it away. And now I'm horribly depressed and I can't function. So it's your fault fault, because if you just give it back to me, then I'll be fine. Right. And so what we actually see happening is that the kid is now in marijuana withdrawal. And so it's not that the marijuana is treating their illness. It's that they put themselves into withdrawal, and now that's layered on top of whatever potential mild to moderate depression that existed in the first place. And so we're seeing this like real worsening in what's happening. One thing that we've actually seen quite a bit of recently among young people is what's called cannabis hyperemesis syndrome. And this is a type of cyclic vomiting syndrome, which impacts individuals, again, more likely in adolescents than in older people who are smoking marijuana. We get a lot of kids who will come in for residential treatment for marijuana use that have been through extensive GI workups in the community because of this like very confusing episodes of inability to eat, vomiting, not being able to go to school. Oftentimes it'll happen more in the morning than at other times because the kids are smoking at night before they go to bed. And then when they wake up, they're in withdrawal. And so it's happening to them. But all these tests, EGD, colonoscopy, nothing comes up. It's all like people don't know why this is happening. And so educating kids that this can be because of the marijuana, it can be pretty serious. We've had kids come in, they've, only thing they were using was marijuana. They end up actually having to be sent out to the ER, sometimes 1-2 times to have fluid repletion because we're doing as best as we can with medication management to manage the nausea and vomiting. But it's that bad that they end up having to be sent out and come back to us a couple of times sometimes. Reason 3 is brain development. And so this is probably the biggest reason that I harp on about why use in adolescence and young adulthood is different than older adults. And that's because the prefrontal cortex is still under development for a young person. And so what we know is that areas of the brain that are not completely formed are more sensitive to the impact of toxins, trauma, and stress. And that when that happens, it can derail the development of that part of the brain and actually shift the developmental trajectory of the brain. And so I'll sometimes use a house analogy. And it's like, well, which house is most likely to be damaged in the event of a hailstorm, right? It's the house without the roof. And so if you think about the prefrontal cortex as the roof and you think about the cannabis as the hail, right, you're much more likely to see damage to the brain happen during this window of time if there is cannabis exposure. And we see the same thing happen actually with trauma, right? When there's trauma exposure during adolescence and young adulthood, we see different impacts on the brain than we do when there's trauma that happens at different points in development. This is a really great review article for anybody that wants to look it up. It does a really great job of summarizing both human studies and rodent studies that show how does marijuana impact the brain when there is exposure during this, what we call sensitive period. And what we see is decrease in executive functioning skills, which can persist beyond the time where the person is actually using. The research that's reviewed in this study showed that the association is the strongest when there is use at or before 16 years old, that's really where we start to see. But we, again, don't have enough data to really be able to give our patients really strict, like clear instructions, right? We can't say, if you use 2 times a week, you're probably safe. Or if you because likely it's also an interaction with genetics. And so in my patients that have, a pre-existing ADHD, I make sure that I tell them about this. I say, your brain already has a hard time with executive functioning, and now you're using the marijuana, and the marijuana is creating even more of a hard time with executive functioning. And what I worry about is that, right now you respond pretty well to your Vyvanse, right? Like you can do okay. And yes, you're smoking, but generally you're doing okay at school. And what I worry about is that like when you're older now, we might not actually have medicine that's strong enough to help you. You might be somebody that kind of has what looks like brain damage, because even if we give you the highest dose of Vyvanse, you still have problems in this area because what you're doing to your brain now is going to combine with your ADHD you already have. And it's going to make it really hard for us to treat you. And I don't want that to happen to you when you're an adult. I want you to be able to be fully functioning and not have to be reliant on medication, and also not have to have accommodations at your job or with your family because your brain is having a hard time. We see decreases in IQ, which preferentially actually impact verbal IQ. And we see physical changes in the brain. So we think that these physical changes are happening from impairments in pruning and myelination, which are supposed to happen in the prefrontal cortex during adolescent time period. And so we see larger prefrontal cortexes, we see increases in gray matter, decreases in white matter, and we see changes when we do fMRI research. So the brain has to use more resources to do the same tasks that require the prefrontal cortex when you're using marijuana or when you have used it than another brain. And so it's requiring more effort for the brain to engage in the task than it would if you hadn't used marijuana. And then reason 4, I think, is a culmination of the rest of the reasons. And so there's an increased risk of addiction with any substance use prior to the age of 18. And so 1 in 4 teens who use any substance before the age of 18 will go on to have a lifelong addiction. And that could be to marijuana, it could be to other substances. And so this increases population risk by 5 to 8 times. This graph is not as striking as the alcohol graph, but you can really see a relationship here between age at first use of cannabis and risk of lifelong adult addiction. And the rate decreases by year. So if you can get your patient to delay the use of their cannabis, you're going to increase their chances of being healthy when they're an adult and not having to struggle with addiction. And so, if you can get your patient who's maybe 13 or 14, who's maybe smoked 1 or 2 times to say, can we wait until you're 16 to smoke? That's better. That's good. Right. And so it might be too much to come on and say, don't smoke at all. But to say, can you wait till you're in college? That is going to be protective for that person's brain. And I just throw this in here because I just find this data so striking because of how normalized alcohol use is for people in our society. But if you're using alcohol at the age of 13, you have a almost 50% chance of having an addiction when you're an adult. And so it's not, again, as striking as cannabis, but, it's just important to remember that people worry a lot about marijuana, and I'm not saying we shouldn't, but alcohol is around, it's in everybody's homes, and it's much more likely to cause morbidity and mortality for young people and for adults than potentially the evidence that we have for marijuana right now. So again, kind of a culmination of the rest of the 3 reasons. And it makes sense, right? Increased exposure to immediate harm and trauma when you're a kid, increased family conflict at that time, worsening of your mental health, difficulty with development of healthy coping skills, which then kind of sticks with you into adulthood, and then, potentially brain damage, right? And you combine all of those 3 things together and you could understand why using marijuana or other substances when you're young increases the risk of addiction in adulthood. So I think I'm going to stop here because we've got only 6 minutes left because I want to have time for a couple of questions because I know this is a lot of content.
Yeah, this is Kurt. So Heather had to drop off, so I'm taking over.
Yeah.
Boy, wonderful talk. A couple questions in the chat, and I'll maybe have Aaron read those in a sec. But first off, to me, it sounds like you're saying the $1 million question that has been asked a million times is it a gateway drug? Marijuana. Yeah,
no, that's such a good question. I have issue with the word gateway because I feel like it's been it just feels so kind of like war on drugs reactionary, you know what I mean? And I think the way to get people to shut down is to use words like that. So I tend to not really talk about things being a gateway or not, because really having depression is a gateway to addiction, because we know it's a risk factor. And so I guess the way that I think about it is, yes, using marijuana is a risk factor for development of use of other drugs. And it would make sense if you think about it, right? So the more risk-taking behavior that you engage in, the more you normalize and believe that, things that are not healthy are fine or healthy, then the more likely you are to continue to take steps down that path of risks and unhealthy choices. And the more likely you are to be surrounding yourself with other people who also feel that way, therefore convincing you that what's happening is okay. So in that way, yes, it's a risk factor, but I just cringe with the word gateway. So
yeah, there was a question in the chat that talked about, well, are we expecting that we're going to see the same effect with prenatal exposure to marijuana as we would if the kid was smoking it? Any data on that?
Yeah, so there is. So that would be a whole talk. But yes, there's a lot of data about the impacts of cannabis on prenatal brain development. And yes, we see the same kinds of things. We see impairments in later on, those children have more struggles with ADHD-like symptoms and executive functioning. So yes, we see kind of that same type of risk. And so, just as a plug again, all about harm reduction. And for pregnant women, right? If we can't get them to not use marijuana, if we can shift them to using something like CBD, even though again, not that that's an awesome idea, but it might be better for their fetus's brain than THC is. So trying to help people to make healthier choices.
One of the things that they saw in Colorado was that there was more alcohol intake, which they thought it would be less when marijuana was legalized. Is there any data for what the effect is on adolescents as far as alcohol intake and marijuana?
Yeah. So when you legalize a substance, you see increases in all other types of substance use. So this notion that by legalizing marijuana, we're going to decrease opioid use or we're going to decrease alcohol use is not true. Because essentially we're just sort of sending the message that substance use is normal in our culture, and we're increasing access to things that alter our judgment. And so, you can totally see the scenario, right, where somebody's like, oh, I'm going to try marijuana because it's legal now. And then now they're not in a space where they're making good decisions. And their home also contains alcohol, because a lot of us have alcohol in our houses. And so then they're also using alcohol, or they're out with people who are using marijuana. And then it happens that the dealer who sold them the marijuana also has some pills. And now you're intoxicated with marijuana and you're not making good choices. You weren't intoxicated, and the person says, oh, hey, you can try one of these pills for free, so then you're more likely to do that. So yeah, it is the case that we see increases in other substances when marijuana is legalized.
Yeah. I don't know if Aaron or Heather wants to read a couple of those others. I've got such glare here I can't see, but.
Yeah, Sarah, again, thank you so much. First of all, we are going to have people reach out to you, or we might have Katie reach back out to you to see if you'll also come back for a third talk on that prenatal development. There's been several comments in there. Question, do you have any just like flyers or handouts or basic information that you use for whether it's parents, families, the kids themselves? Just because this was such a great overview.
Yeah. Yeah. So, yes. So I will say that the materials that I really like the best, if you type in SBIRT, SBIRT, there is an entire PDF packet that includes not only little guides for you to use as a clinician, but also handouts for patients and families about alcohol and cannabis, and definitions of things like standard drink, helping parents to understand what, a blunt is, what a joint is, all that kind of stuff. So that's one resource. SAMHSA, yes. Also has other resources that are great, that are printable, that you can print out, that kind of give information about marijuana and the way that marijuana impacts teens differently than adults. So I would really just direct you to the SAMHSA website. NIDA, National Institute of Drug Abuse, has some great resources that are for teenagers. And then the SBIRT materials are some great things. And then there's a question about the CRAFT screen validated in pregnant women. So it's been validated for ages, not for pregnancy status. And so if you have a person who's pregnant, who's under the age of 25, then yes, it's validated for that person. And I don't know if there's specific screens that are just for pregnant women. There's something called the audit, which is AUDIT, which is also very evidence-based as a substance use screening tool that's validated in adults. And so that's one that you could use in that population. But yep.
Yeah, the only validated ones in pregnancy is the 4 Ps, the 5 Ps is under investigation right now, and then the SERP.
Oh, that's interesting.
Investigation as well.
Oh, that's interesting. Do they think that the other adult screening tools are not valid in pregnant women, or is it just that they're not special for pregnant women?
They're not special for pregnant women. So there's really not a consensus statement on it. Ultimately, it just says screen, and a urine drug screen doesn't count. So it's some type of screening, and everyone wants one specific to pregnancy, which I don't really love the specific to pregnancy ones, but I think ultimately if you're screening, you're not going to go wrong.
Yeah.
One quick just comment that I wonder if you have a thought about. It's like I just recently had a lawyer call me about a patient with a Delta 8 level, wondering what it meant. And to my knowledge, there's no good studies that show impairment related to those levels. And really in all of the cannabinoids, that's tough to, there really isn't anything that's very solid science-based, is there?
No, yeah. And that's like hard part right now, and something that I hope changes. But right, it's like when it comes to alcohol, we've got all this data because it's legal. So we can kind of, we have a legal limit for driving, we have a roadside test, all this kind of stuff. And we don't have any of that for marijuana. So yeah, it's really hard to know. I mean, from a theoretical perspective, Delta 8 interacts with both the CB1 and the CB2 receptors. It's just less potent than Delta 9. So theoretically, enough Delta 8 would impair someone. It's just a matter of like, we don't know how much, or if that means they shouldn't be doing certain things, or yeah, it's real tricky.
Yeah. All right. Any other questions? Heather, anybody want to unmute and ask any other ones?
I think it helps that she's coming back in a couple weeks. So everybody just write your questions down and save them.
Yeah, I'll leave more time next time too, because my other deck is a lot shorter than this. And so we can have more time to talk through some cases and stuff.
Perfect. Well, thank you again. And everybody check out her Instagram.
If you want, just don't make fun of me, but you're good. Thank you.